The human upper limb contains 32 bones, 5 principal joints, dozens of fascial compartments, and a complex electrical grid known as the brachial plexus. Attempting to memorize this data through flashcards leaves you with a disconnected list of facts. In a high-pressure clinical emergency, like a traumatic wrist laceration, there is no time to flip through mental index cards. Surgeons rely on structural logic. They view anatomy as an interconnected system where specific physical coordinates dictate exact neurovascular pathways. We can navigate these complex regions by applying a consistent deductive framework. This framework is built on 7 sequential questions: name, location, parts, relations, supply, function, and clinical correlate. Applying this pattern shifts you from passively staring at diagrams to actively predicting pathology based on structural rules. We begin at the base anchor point. The upper limb attaches to the axial skeleton at the root of the neck, with the scapula positioned to glide over the ribs of the posterior thoracic wall. From here, the framework extends through the clavicle into the humerus of the arm, the radius and ulna of the forearm, and finally into the 27 bones of the wrist and hand. This skeletal foundation allows us to run our 7-step analysis to build the limb, layer by layer. The physical geometry of the bone, its ridges, grooves, and necks, establishes the mandated pathways for every nerve and blood vessel. Take the humerus. Its critical parts include the proximal surgical neck, midshaft radial groove, and distal epicondyles. These landmarks create physical choke points. The axillary, radial, and ulnar nerves must wrap tightly around the bone to reach their target muscles. When we reach the clinical correlate, the logic is immediate. Because the axillary nerve curves directly around the surgical neck, a fracture at this site directly threatens the nerve's integrity. Severing the axillary nerve denervates the deltoid. The patient presents with deltoid paralysis and a loss of shoulder abduction beyond 15 degrees. At the midshaft, a fracture at the radial groove severs the radial nerve. This cuts the electrical supply to the extensors, resulting in wrist drop. At the distal end, a fracture of the medial epicondyle damages the ulnar nerve, paralyzing the intrinsic hand muscles and causing a claw-hand deformity. The clinical rule is consistent. A specific fracture site mandates a specific neurovascular risk. The same structural rules apply to the joints. The glenohumeral joint pairs the large spherical head of the humerus with the shallow glenoid cavity of the scapula. This provides the greatest range of motion of any joint in the body, but it achieves that mobility by sacrificing physical stability. Stability is instead provided by the rotator cuff, the sits muscles. These tendons wrap tightly around the humeral head to act as dynamic stabilizers, holding the ball within the socket during movement. When this dynamic stabilization fails, the joint dislocates. In 95% of cases, the humeral head translates antero-inferiorly. Mapping the relations of the joint reveals the secondary injury. As the bone slides downward, it stretches the axillary nerve, sitting just below the joint capsule. To diagnose the extent of the damage, the clinician must check sensation over the lateral deltoid to confirm the nerve is still intact. Joint pathology is predictable once you map the physical borders that limit its mobility. Muscles are organized into sealed, high-pressure spaces called fascial compartments. Muscles within a shared fascial space share a common physiological function and a common nerve supply. The posterior compartments of the arm and forearm are dedicated to extension and are supplied exclusively by the radial nerve. The anterior compartments are dedicated to flexion. They are powered by the musculocutaneous nerve in the arm and primarily the median nerve in the forearm. There is one highly notable clinical exception. The flexor carpi ulnaris and the medial half of the flexor digitorum profundus are located anteriorly but are supplied by the ulnar nerve. Because these compartments are enclosed in unyielding fascia, severe swelling can cause internal pressure to spike, choking off arterial blood flow. This is compartment syndrome, a surgical emergency. Knowing these compartment rules allows you to deduce the damaged nerve based solely on which functional action is lost. This compartment system is driven by the brachial plexus, an electrical grid originating from the C5 to T1 nerve roots in the neck. Proximal injuries at the upper trunk result in Erb's palsy, or waiter's tip posture. Injuries at the lower trunk primarily affect the intrinsic muscles of the hand. As nerves travel distally, they encounter new entrapment zones, such as the carpal tunnel at the wrist. This rigid space is tightly packed. The median nerve must share the tunnel with 9 separate flexor tendons. Inflammation within this space increases the internal pressure, leading to mechanical compression of the median nerve. This causes thenar wasting, known as apand, and a loss of sensation in the lateral 3.5 digits. Peripheral nerve injuries are mechanical problems, dictated by the rigid anatomical borders containing them. Mastery means observing a physical deformation and tracking it backward to the structural lesion. With wrist drop, lost extension means posterior compartment failure, compromising the radial nerve. A claw hand indicates failing intrinsic muscles, tracking to the ulnar nerve at the medial epicondyle. Apand denotes thenar denervation, pointing to the median nerve in the carpal tunnel. The nerve innervates the compartment, and the compartment dictates the action. The 7-step meta pattern organizes the dense data of the upper limb into a structural map, transforming anatomical facts into a tool for clinical deduction.